It's kind of funny how Hollywood has completely programmed our brains when it comes to survival scenarios.
Oh, absolutely. It's totally ingrained in us.
Right, like you see it in almost every single action movie set in the jungle or, the desert. Someone is walking along, there's a sudden rattle or a hiss, a quick strike, and then just total panic.
The classic snake bite scene.
Exactly. The hero whips out this giant survival knife, slices an X right over the wound, tries to suck out the poison with their mouth, or maybe they rip off their belt and tie it as a tourniquet as tight as they possibly can around their friend's thigh.
Right, to stop the venom from reaching the heart.
Yeah, and it's dramatic, it's super intense, and, well, as we're going to explore today, it's also completely disastrously wrong.
Yeah, the gap between what we think we know about venomous encounters and the actual clinical reality is just dangerously wide.
Dangerously wide.
Because in a lot of those cinematic survival tactics, the hero is basically guaranteeing that the victim loses a limb, or worse, suffers a fatal systemic collapse. Yeah, the interventions we see on screen, they often actually accelerate the exact biological destruction they're trying to prevent.
Okay, let's unpack this because closing that gap is our absolute mission for you today. Welcome to another deep dive. We've managed to get our hands on some incredibly rigorous clinical data, focusing specifically on envenomation.
Right. Stings and snake bites.
Yep, compiled by Dr. Magdalene Fatakemi. And what makes this particular stack of research so compelling is the really heavy focus on pediatric data.
Which changes everything, really.
It does, because when you look at the actual clinical reality, the stakes are just exponentially higher, and the timeline is terrifyingly compressed when a child is involved.
Absolutely. The margin of error practically vanishes.
Exactly. So we're going to build this from the ground up for you today. We'll start with the biology of the threat, move through the catastrophic internal chain reaction of the venom, debunk all those Hollywood myths, and finally unpack the incredibly volatile tightrope walk that is the hospital treatment.
Well, I think we have to start by drawing a really clear line between the different types of threats you might actually encounter out in the bush.
Okay.
Because, stings and bites present totally different medical challenges. A sting from a bee, a wasp, or certain ants is undeniably agonizing. We all know that.
Oh, yeah, it's the worst.
But fundamentally, the venom introduced by those insects is not intrinsically dangerous to the human nervous or vascular system in the way a snake's is.
Right, right. Like when someone, unfortunately, dies from a bee sting, it isn't because the bee's venom melted their internal organs.
No, not at all.
It's because their own immune system basically decided to hit the nuclear button, the anaphylactic reaction.
Exactly. The body misidentifies this tiny, relatively harmless foreign protein as a massive systemic threat.
And the resulting immune overreaction is what closes the airway and crashes the blood pressure.
Yeah.
It's basically our own body turning against us.
That is the crucial distinction to make right out of the gate. With anaphylaxis, the damage is essentially self-inflicted by the immune system. But when we transition to venomous snake bites, the dynamic shifts entirely.
It's a whole different ballgame.
It is. We are no longer dealing with a mere allergy. We're dealing with an active, highly specialized biological weapon literally entering the system.
But what's crazy is that the sheer variety of those weapons is surprisingly narrow. When you look at the global snake population,
Arceus.
the numbers in the research really recalibrated my own fear of snakes, honestly, because out of over 3,000 known species of snakes globally, only about 200 are actually poisonous to humans.
That's right, just a fraction.
It's like finding a needle in a haystack. That's roughly 6%. Most snakes are not out to kill you, and the ones that can do severe, life-threatening damage fall into very specific taxonomic families.
And establishing that baseline is super important for understanding the actual risk out there. The vast majority of snakes belong to groups like the Colubridae family.
So that's the pythons and boas.
Pythons, boas, anacondas, yeah.
Yeah.
They rely on mechanical force, constriction, rather than chemical warfare. But 90% of the dangerous, venomous minority belongs just three main families.
Okay, let's list those out.
First, you have the Hydrophidae, which are the sea snakes.
Sea snakes, got it.
Their venom is exceptionally toxic, though. Thankfully, human encounters are pretty rare.
Unless you're a deep sea diver, I guess.
Right. Then you have the Elapidae family. That's your cobras, your mambas, and coral snakes.
Really famous one.
Yeah. And finally, the Viperidae, the true vipers, which includes pit vipers, rattlesnakes, cottonmouths, and copperheads.
I want to pause on the venom itself for a second,
Hmm.
because we use the words venom and envenomation interchangeably in everyday conversation, right?
Yeah.
But medically, they describe totally different things.
Very different, yeah.
Venom is the actual substance, the physical liquid. And looking at the evolutionary biology of that liquid is just fascinating. It wasn't designed to murder humans who accidentally step on a hiking trail.
No, not at all. What's fascinating here is that, evolutionarily speaking, venom serves two primary purposes: capturing prey and digesting that prey.
Defense is almost an afterthought.
Defense is almost a secondary benefit. If you think about a snake's anatomy, they don't have limbs to hold down a struggling rodent,
Right.
and they don't have molars to chew their food up. They have to swallow their meals completely whole. So the venom acts as a highly concentrated external digestive juice.
So it does the chewing for them, essentially.
Exactly. It's designed to immediately immobilize a fast-moving animal and then basically begin breaking down its tissues from the inside out.
Yeah.
It turns the prey's internal organs into a slush, so the snake's relatively simple digestive tract can actually process it.
Oh, so when a human gets bitten, we are basically experiencing the snake's digestive process while we are still alive.
That's a gruesome but accurate way to put it.
That explains why the tissue damage is so catastrophic. But getting bitten doesn't always mean you're going to experience that, right? The notes draw a really hard line between the presence of venom and the actual act of envenomation.
Yes, because envenomation is the successful event. It's the actual physical introduction of that venom into the body system of a warm-blooded animal and the subsequent manifestation of its effects.
Meaning the snake actually fired the gun, so to speak.
Right. You can be struck by a highly venomous viper, but if it doesn't actually compress its venom glands and inject the liquid, you have not suffered envenomation.
And clinicians call that a dry bite.
Right, a dry bite, exactly.
Mm.
The snake might just be delivering a warning strike to get you to back off. It doesn't want to waste its biologically expensive venom on you.
Which makes sense. They don't want to waste their digestive tools on something they can't even eat, like a human leg.
Precisely.
So, knowing who the culprits are and what the weapon actually is leads us right to the epidemiology. Who is actually getting bitten? Because the clinical data shows this isn't just random bad luck.
No, there's a very specific social and geographic pattern to these encounters, especially in regions like Africa and Asia.
What does the data show?
It paints a picture of accidental habitat collision. The vast majority of bites occur on the lower limbs, typically from the knee down.
Makes sense if you're stepping on them.
Yeah, and they happen most frequently at night or in the early evening. And they're usually provoked by someone simply walking and accidentally stepping on a snake that's hunting or just resting in the brush.
So the snake is just minding its own business.
Right. The snake feels crushed, it panics, and it strikes at the nearest object, which is the person's ankle or calf.
The research also highlights specific occupational hazards, though. We're talking about activities that put people right into the snake's living room.
Exactly, like hunting.
Yeah, specifically hunting for small game like rabbits, where you're actively reaching into burrows or walking through really tall, uncleared grass.
Or clearing bushes around a property. Or working as zoo staff where you're actively handling these animals daily.
Right. But I want to circle back to the pediatric aspect because the clinical notes really emphasize that children are far more likely to suffer a severe systemic reaction to envenomation.
It's a critical point in the data.
What are the actual mechanics behind that vulnerability?
Okay.
Because a bite is a bite, right?
Well, it comes down to basic volume distribution and body mass. The amount of venom a snake injects during a strike is entirely independent of the target size.
So the snake doesn't dial down the dose for a kid.
Not at all. A rattlesnake delivers roughly the same payload, let's say 50 milligrams of venom, whether it strikes a 200-pound farmer or a 40-pound child.
Man, I was trying to visualize this earlier. It's like taking a single drop of highly concentrated dark red food coloring, right?
Okay, I like this.
If I drop that dye into a giant swimming pool, which represents the adult's vascular system, it disperses, it dilutes rapidly, and it barely changes the color of the water at all. The concentration is incredibly low. But if I take that exact same drop of dye, the same 50 milligrams, and put it into a small shot glass, which is the child's body, the entire glass instantly turns deep red. The concentration is incredibly high, right from the very first second.
That analogy maps perfectly onto the human vascular system. Because a child has a much smaller total blood volume, that 50 milligram payload of venom reaches a toxic systemic concentration almost immediately.
So it's just racing through their system.
Exactly. The distribution of those destructive enzymes to their vital organs, the heart, the kidneys, the lungs, it happens incredibly fast.
They're terrifying for a parent.
This is why time is an absolute luxury you do not have in pediatric cases. A child's physiological status can deteriorate from stable to critical in a fraction of the time it would take an adult. The margin for clinical error is essentially zero.
Let's follow that dye into the shot glass then. What is actually happening in the water? The pathophysiology section of Dr. Fitakami's research is super dense, but it's really critical for understanding why the body fails so spectacularly.
It is dense, but it's fascinating.
Because snake venom isn't just one simple poison, is it?
Yeah.
It's like a biological cocktail.
It's a completely chaotic mixture of enzymatic proteins. You've got polypeptides, glycoproteins, vasoactive substances, and proteolytic enzymes.
Proteolytic enzymes, let's break that down, because the term literally means protein destroying, right?
Right.
These act like microscopic biological scissors. They're designed to snip the chemical bonds that hold tissue cells together.
That is a highly accurate way to look at it. The venom of the Viperidae family, the pit vipers and rattlesnakes, is particularly devastating because it's heavily cytolytic and hemotoxic.
Okay, let's define those for sure.
Cytolytic means it destroys individual cells, literally causing them to rupture. Hemotoxic means it specifically targets the blood and the body's cardiovascular infrastructure.
The research notes that the venom damages the vascular endothelium. That's the really delicate, single-cell thick inner lining of your blood vessels, right?
Exactly. And once those proteolytic enzymes, your biological scissors, start snipping away at the endothelium, the structural integrity of your blood vessels just collapses.
Oh, wow.
Imagine the sturdy plumbing pipes in your house suddenly turning into highly porous cheesecloth.
That sounds like a disaster.
It is. This causes immediate severe vascular leakage. The plasma, the liquid serum from your blood, literally escapes out of the vessels and floods into the surrounding muscle and subcutaneous tissues.
Which explains the horrifying rapid swelling, the massive edema that we see with severe bites.
Yes, exactly.
That fluid pooling under the skin isn't just an inflammatory response like a swollen ankle. It is literally the patient's blood volume leaking out of their plumbing system and getting trapped in the limb.
It's plasma loss.
Yeah.
And that localized pooling of fluid is just the beginning. The hemotoxic aspect is where it becomes systemic, and this leads us to one of the most dangerous and complex biological paradoxes in all of medicine.
Consumptive coagulopathy.
Consumptive coagulopathy.
Here's where it gets really interesting. Because I have to admit, when I first read the term consumptive coagulopathy in the notes, it sounded completely contradictory.
It does sound like an oxymoron.
Let me see if I understand this mechanism, because it totally blew my mind. Normally, if you get a cut, your body sends platelets to the site, and a protein called fibrin acts like a microscopic net to trap red blood cells.
Right, to form a clot and stop the bleeding.
It's a highly regulated, very localized process.
Right.
But venom throws a wrench into that system.
It doesn't just throw a wrench, it hijacks the entire factory.
How so?
The widespread destruction of the blood vessel walls, that cheesecloth effect, sends a massive systemic panic signal to the brain. The body realizes it is leaking everywhere all at once.
Panic mode.
Total panic mode. So in response, it inappropriately triggers the coagulation cascade into hyperdrive. It starts frantically forming millions of tiny microintravascular clots throughout the entire circulatory system, not just at the bite site.
Everywhere. So it's clotting everywhere. But wait, why does that make the patient bleed out? That's the paradox.
Because the body's supply of clotting materials is finite. You only have so much fibrinogen, so many platelets, and so many coagulation factors circulating at any given time.
Oh, I see.
The venom forces the body to use up or consume all of its available clotting factors to build these millions of completely useless microclots.
So it's consuming its own defense.
Exactly. Within hours, the body completely runs out of the raw materials needed to form a blood clot anywhere.
So it clots so aggressively that it bankrupts its own supply chain. And once that supply is gone, the blood basically loses all structural integrity. It just turns to water.
The end result is total incoagulability. The patient begins to bleed spontaneously from absolutely everywhere.
Everywhere.
They bleed from their gums, their eyes, old IV puncture sites, and most dangerously, they hemorrhage internally into their brain or their abdominal cavity.
The domino effect of that is just staggering to think about.
And that systemic collapse is what ultimately causes mortality. The clinical presentation is very explicit here. Death from pit viper bites doesn't usually happen because the venom stops the heart directly, like a neurotoxin might.
Right.
It results from hemorrhagic shock due to the massive internal bleeding we just outlined. It results from adult respiratory distress syndrome, or ARDS, where the lungs fill with leaked fluid and fail. And it results from acute renal failure.
Let's talk about the kidneys for a second, because they clearly take a massive hit. Why do the kidneys fail? Is the venom attacking them directly?
No, it's more of an indirect mechanical failure.
Okay, walk me through that.
The kidneys are your body's filtration system. As the cytolytic venom destroys muscle tissue at the bite site, a massive amount of a protein called myoglobin is released into the bloodstream.
From the dead muscle?
Right.
Wow.
Combine that with millions of destroyed red blood cells from the venom, the kidneys frantically try to filter all of this cellular garbage out of the blood.
But it's too much.
Way too much. The microscopic tubules inside the kidneys get physically clogged by the sheer volume of debris. They choke, they completely shut down, and the patient goes into acute renal failure.
Wow. Okay, so we've established this invisible catastrophic war happening inside the vessels. But when a patient is rushed through the hospital doors, the doctors can't see the microscopic destruction of the endothelium.
We can't see the cheesecloth.
Right. They have to look for the physical footprint of that vascular collapse. How does the clinical team examine the patient and actually grade the envenomation in real time?
They rely on a strict timeline of symptom progression. Almost immediately after the strike, within minutes, the patient will experience intense local pain and swelling directly at the site of the fang marks.
Which is to be expected.
But pain alone isn't enough to quantify the danger. The true measure of envenomation is tracking the physical spread.
The spread of the swelling.
Yes. As the venom moves proximally, meaning it travels up the limb toward the core of the body, the edema advances with it. And trailing right behind the swelling is the ecchymosis, the severe bruising.
So the bruising is essentially a map on the skin. It's literally tracking the venom's destructive path through the lymphatic system and the local blood vessels.
Precisely. The proteolytic enzymes are destroying capillaries as they move, leaving a visible trail of subcutaneous bleeding.
That's terrifying to watch, I imagine.
It is. In severe cases, the tissue damage becomes so profound that you actually see the formation of large bullae.
Bullae, what are those?
They are massive, fluid-filled blisters that bubble up on the skin. This is eventually followed by tissue necrosis, where the flesh around the bite site loses its blood supply entirely, it dies, and it turns black.
And what about systemic signs? What are they watching for beyond just a bitten limb?
Systemically, the patient might present with severe nausea, vomiting, and diaphoresis, which is profound, soaking sweat as the autonomic nervous system just panics. Neurologically, even with hemotoxic venom, you can see crossover effects, tingling around the face, puerile paresthesias around the mouth, and muscle fasciculations.
Fasciculations, like spasms.
Yeah, visible involuntary twitchings of the muscle fibers right under the skin. And if the consumptive coagulopathy has progressed, you'll see that spontaneous bleeding we talked about and a crashing blood pressure indicating hemorrhagic shock.
Now, to make sense of all this chaos in an emergency setting, the source outlines a specific grading scale, from grade 0 to grade 3.
Yes, the standard grading scale.
I want to look closely at grade 0, because this is interesting. Grade 0 is the dry bite. The clinical definition is no envenomation, minimal pain, no swelling.
Right.
But I have to imagine if a patient comes rushing into the ER, they were terrified, their adrenaline is completely through the roof, they have 2 physical puncture wounds in their leg, and their leg hurts. How on earth does a clinician know right then and there if it's a grade 0 dry bite or just the very first 5 minutes of a grade 1?
That is the exact dilemma.
Because visually, they have to look identical at minute 10.
Right.
Grade 1 is defined as having minimal local pain and swelling.
It's the thing that makes treating snake bites so incredibly tense for emergency physicians. You cannot definitively call it a grade 0 the moment they walk through the door. You simply can't.
So what do you?
The crucial diagnostic tool isn't a single snapshot observation. It is the observation of progression over time.
Okay.
Envenomation is a highly active, moving process. If you mark the edge of the swelling with a pen and 2 hours go by and the swelling hasn't moved a single millimeter past the fang marks and their blood pressure is totally stable, you're likely looking at a grade 0.
The pain is just purely from the mechanical puncture of the fangs.
Exactly. Just a wound.
But if you see what's described in grade 2, which is moderate envenomation, that waiting game is over. Grade 2 is defined by the progression of swelling, erythema, or bruising, clearly extending beyond the site of the bite.
Yes, the progression is undeniable at that point. The swelling is actively marching up the calf or the forearm.
Marching. That's a good word for it.
And grade 2, this local progression is coupled with non-life-threatening systemic signs. The patient starts vomiting, their face tingles, or their blood pressure begins to dip mildly. The venom is clearly systemic.
And then there's grade 3, severe envenomation. This sounds like an absolute nightmare scenario.
Grade 3 is a dire, immediate medical emergency. The localized swelling isn't just marching anymore, it involves the entire bitten extremity.
The whole thing.
If they were bitten on the foot, the entire leg from the toes to the hip is swollen, discolored, and agonizing. Systemically, their systolic blood pressure crashes below 80.
Wow.
They exhibit an altered sensorium, meaning the brain isn't getting enough oxygen, so they're confused, lethargic, or entirely unconscious. They have tachycardia, tachypnea, and crucially, they present with that completely deranged, unmeasurable clotting profile.
They are in active hemorrhagic shock.
Yes.
Now, obviously, a patient doesn't just teleport into the ER grade 3. There is a critical window of time before they reach the hospital, the pre-hospital care phase.
The actions taken in the dirt.
Exactly. On the side of the trail or in the back of a pickup truck. And this brings us right back to our opening hook about Hollywood and folklore. Because the clinical data provides a very explicit list of common field practices that are not only ineffective, but actively, horrifically harmful.
If a listener takes only one piece of actionable information away from this entire deep dive, it must be this list. You have to unlearn the folklore.
Let's go through it.
Do not apply cold packs or ice to the bite. Do not use black stones. Do not use the cut and suck method. Absolutely do not apply a tight tourniquet. And do not, under any circumstances, use electroshock therapy.
Okay, I have to stop you at electroshock therapy. Applying high voltage from a stun gun or a spark plug to someone who has just been injected with a highly destructive enzyme. Where did that idea even come from? It sounds like medieval torture.
It really does. It stems from a fundamental misunderstanding of biochemistry. Decades ago, a theory circulated that because venom is made of proteins, applying a high-voltage electrical current would denature or cook those proteins, rendering them harmless.
Like cooking an egg white.
Much like heat cooks the proteins in an egg white, yes. But in practice, you cannot deliver enough electricity to actually denature the venom in deep tissue without severely burning the patient and causing massive secondary tissue damage.
So you're just adding an electrical burn on top of necrosis.
Exactly. It's barbaric and useless.
And what about the black stones? I've read about these in historical accounts. They're supposed to magically suck the poison out, right?
It's a very persistent myth, particularly in parts of Africa and Asia. A black stone is usually a piece of highly porous, charred animal bone.
Just bone.
Yeah. The folklore suggests that if you press this dry, porous bone against the wound, it will act like a sponge and pull the venom out. Clinically, it does absolutely nothing.
Because the venom is too deep.
Exactly. The venom is injected deep into the subcutaneous tissue or muscle, often tracking instantly into the lymphatic system. A piece of bone on the surface of the skin cannot reverse capillary absorption. It only delays the patient from seeking actual medical care.
Let's address the most famous one, though. The cut and suck. The hero slices an X over the fang marks and sucks the blood out. Why is this so dangerous? If the venom is in there, doesn't it make sense to try and vacuum it out?
It makes mechanical sense until you understand the human anatomy. The danger isn't just the oral suction, it's the blade.
Oh, the cutting.
When you take a knife and slice into an envenomated bite site, you are physically slicing open hundreds of healthy capillaries and blood vessels that weren't damaged yet.
Oh, wow. I never thought of that.
You're destroying the tissue barriers that might be temporarily slowing the venom down. You are literally paving a wider highway for the venom to enter the systemic circulation faster.
That is counterproductive.
Highly.
Yeah.
Furthermore, the human mouth is teeming with virulent bacteria. By sucking on an open wound, you are introducing a massive infection risk to an area where the immune system is already completely compromised.
But the clinical notes do mention something interesting in the correct treatment section. They mention applying a suction agent like a Sawyer extractor is sometimes used. So, mechanical suction over the existing fang marks without cutting the skin is a different story.
It's different because it doesn't involve lacerating the tissue. A mechanical pump placed over the intact fang marks creates a vacuum that might draw out a minute fraction of venom if applied within the first few minutes.
But does it work?
However, modern toxicology has heavily debated their efficacy. Most studies show they pull out very little venom and can actually sometimes increase local tissue damage due to the intense vacuum pressure.
But what is absolutely not debated, and what is almost universally condemned by modern medicine, is the tight tourniquet. Tying a belt tightly around the upper thigh, we've all seen it done. Why is it a death sentence for the limb?
Because of the cytolytic pathology we discussed earlier, remember, Viperidae venom melts tissue. If you tie a belt tightly enough to cut off arterial blood flow, you are trapping 100% of that highly destructive flesh-eating enzyme in the lower leg. You're ensuring that the local concentration remains impossibly high.
You're sealing the bomb in the room.
Exactly. You might temporarily prevent the venom from reaching the systemic circulation, but you are almost guaranteeing total tissue necrosis in that trapped limb. The tissue will turn gangrenous, and the eventual result is almost always surgical amputation.
You're trading a leg for a few extra minutes. It's
Yeah.
horrifying. So if we toss the cinematic script and the folklore in the garbage, what is the actual evidence-based field treatment? What should someone do if they are hours away from a hospital?
The primary goal of pre-hospital care is to slow the spread of the venom through the lymphatic system without destroying the limb. First, clean the wound with an antiseptic to prevent secondary bacterial infection.
Keep it clean. Okay.
You can apply an absorbent gauze pad tightly against the wound, but the gold standard is applying an absorption-delaying compression bandage.
The notes specify a crepe bandage. How tight are we talking? Like wrap it as hard as you can.
No, you wrap it firmly. Starting from the bite and working your way up the limb, it should be about as tight as you would wrap a severely sprained ankle.
Okay, so snug but not cutting off circulation.
The key is that you must be able to slide a finger under the bandage. It should compress the superficial lymphatic vessels, which is the primary highway the venom uses to travel, but it absolutely must not cut off the deep arterial blood flow pulsing to the foot or the hand.
So you're creating a traffic jam in the lymphatic system, but the limb is still getting oxygenated blood.
Exactly. Next, you must completely immobilize the bitten area, often with a splint. Muscle movement physically acts like a pump, squeezing the lymphatic vessels and pushing the venom toward the core faster.
So walking is a bad idea.
Keep the patient incredibly still. And finally, keep the limb in a gravity-neutral position roughly at the level of the heart.
Don't elevate it.
Do not elevate it high above the head, as that accelerates drainage to the core, and do not let it dangle down, which increases localized swelling. Just keep it neutral, keep them calm, and get them to a hospital immediately.
Okay, so the patient has been stabilized in the field using the correct pressure immobilization technique. They roll through the ER doors. This starts the critical hospital phase. By the time they arrive, the clinical team isn't just guessing based on the bruising. They have to actively look inside the body to quantify the exact internal damage.
Right, they need hard data.
The clinical notes provide an extensive, highly technical list of required laboratory investigations. Let's try to group these so we can understand what the doctors are actually hunting for. It looks like they're essentially filling 3 diagnostic buckets: checking the blood's structural integrity, checking the filtration system, the kidneys, and checking the engine, the muscles and heart.
If we connect this to the bigger picture, grouping them like that makes the clinical workflow much easier to follow. If we dive into your first bucket, the blood's structural integrity, this is where the medical team is hunting for the footprint of that consumptive coagulopathy we spent so much time on earlier.
So what's the first test?
The very first thing they draw blood for is grouping and cross-matching. They do this immediately because they know this patient is at extremely high risk for massive internal bleeding and will likely need emergency blood transfusions.
And then they run an FBC, a full blood count, alongside a platelet count. What is the venom doing to those numbers?
In a severe hemotoxic bite, those numbers are basically in free fall. The doctors are looking for a rapidly decreased packed cell volume, or PCV, which indicates red blood cells are being destroyed or lost to internal bleeding.
And the platelets?
They're watching the platelet count plummet as those platelets are consumed in those microclots. Conversely, they'll often see a highly elevated white blood cell count as the immune system registers the massive tissue trauma and mounts an inflammatory response.
But the FBC doesn't tell them how fast the blood is actually clotting, right? For that, they need specific coagulation markers. The notes list PT, PTT, fibrinogen levels, and fibrin degradation products. I know these are standard hematology tests, but how do they work in the context of venom?
Let's look at the PTT, the partial thromboplastin time. It literally measures the number of seconds it takes for a sample of the patient's blood to form a clot in a test tube. A normal time might be around 25 to 35 seconds.
Okay.
But in a severely envenomated patient whose clotting factors have been consumed, that time stretches out infinitely. The blood simply stays liquid in the tube. It might take minutes or it might not clot at all.
And the fibrin degradation products, that's a mouthful.
That is a fascinating marker. Fibrin is the protein that forms the microscopic mesh that holds a blood clot together. As the body frantically builds those millions of useless microclots and then naturally tries to break them down again, it leaves behind fragments of that broken fibrin mesh floating in the blood.
Like debris.
Exactly. A high level of fibrin degradation products is the smoking gun proving that consumptive coagulopathy is actively occurring.
Okay, moving to the second bucket. The filtration system. The kidneys. The doctors run E and U, which stands for urea and electrolytes, in a full urinalysis.
These tests provide direct chemical evidence of impending renal failure. They are looking to see if the urea and creatinine levels in the blood are spiking, which happens when the kidneys can no longer filter toxins out of the bloodstream.
Yeah, the urinalysis.
The urinalysis is crucial because they're looking for microscopic blood in the urine or the presence of myoglobin, the muscle protein we discussed earlier, which proves the kidneys are physically choking on cellular debris.
And your third diagnostic bucket covers the engine, the muscles, and the heart. The notes mention the SGOT test and the CPK test.
CPK, or creatinine phosphokinase, is an enzyme found primarily in your heart and skeletal muscle. When muscle tissue is severely damaged or dies, which is exactly what the cytolytic venom is doing at the bite site, the cells rupture and dump massive amounts of CPK into the bloodstream.
So it's a marker for muscle death.
A skyrocketing CPK level is a direct, measurable indicator of widespread skeletal muscle death. Finally, an ECG, an electrocardiogram, is absolutely mandatory for any patient presenting with an irregular heartbeat.
To check the heart rhythm.
Yes, to monitor for direct cardiac involvement or arrhythmias caused by electrolyte imbalances as the kidneys fail.
So the doctors have the physical grading from looking at the expanding bruising on the leg, and they have the microscopic grading from all these lab results. And this leads to the most critical juncture in the entire clinical presentation. These lab results aren't just for putting a name to the damage. They are the exact roadmap that dictates the definitive treatment.
The clinical investigations dictate the intervention entirely. You do not just reflexively pump a patient full of antivenom simply because they report being bitten by a snake.
Wait, really? You don't just give it automatically?
Absolutely not. Antivenom is a highly complex, potentially dangerous biological product. The medical team uses the clinical grading and the laboratory results to determine strictly if antivenom is indicated, which specific type to use, and precisely how much to administer.
Section 7 of the notes outlines the strict indications for pulling the trigger on antivenom. It's a very specific checklist. Swelling that extends beyond the wrist or ankle within just a few hours of the bite. Swelling that involves more than half of the entire bitten limb.
Right.
Any clinical signs of hypotension or hemorrhagic shock. An abnormal ECG. Any neurotoxic signs like paralysis, muscle weakness, or drooping eyelids. Or if those hematology labs come back showing incoagulable blood or spontaneous bleeding. If any of those boxes are checked, the clinical team moves immediately to the antivenom protocol.
Once the decision to administer is made, the clinician must choose between two primary types of antivenom, monovalent and polyvalent.
What's the difference?
Monovalent antivenom is highly specialized. It is engineered specifically to neutralize the venom of one single snake species. Because it's highly targeted, it's exceptionally effective, and crucially, it requires a lower volume of serum, making it significantly less likely to cause severe allergic reactions in the patient.
But the massive catch there is that you have to know exactly what snake bit the patient. If the bite happened at midnight in the thick brush, and the snake instantly slithered away into the dark, the patient might just say, well, it was a brown snake. That doesn't give the doctors much to work with.
Which is the reality in a huge percentage of emergency cases. When the offending species is unknown, the medical team is forced to use polyvalent antivenom.
Polyvalent.
Polyvalent is a broad-spectrum cure. It contains a mixture of antibodies active against a wide range of venoms endemic to that specific geographic region. For example, one vial might contain antibodies capable of neutralizing venom from local cobras, kraits, and vipers all simultaneously.
That sounds incredibly convenient, actually, like a silver bullet. But there's a very dark downside to using polyvalent, isn't there?
A very significant downside. To understand why, you have to understand how antivenom is actually manufactured. It's not synthesized in a chemistry lab. It's a biological product, typically produced by hyperimmunizing large animals, most commonly horses or sheep.
Wait, so they are actually injecting venom into horses?
Yes. Over a period of months, they inject incredibly small, sublethal, gradually increasing doses of specific snake venoms into a horse.
Oh.
The horse's powerful immune system recognizes the venom as a foreign protein and produces massive amounts of targeted antibodies to neutralize it. Once the horse has built up a high titer of these antibodies, a small amount of the horse's blood is drawn.
Okay, I'm following.
In a laboratory, they separate the plasma, purify those specific antibodies, and bottle them. That is the antivenom.
That is fascinating. So when a patient receives antivenom, they are literally receiving horse proteins.
Exactly. And this is where the danger of polyvalent antivenom lies. Because polyvalent has to cover multiple snake species, it contains a significantly higher total volume of animal-derived proteins than monovalent.
It's thicker, essentially.
When you intravenously pump massive amounts of foreign horse protein into a human being, the human immune system often recognizes it as a massive alien invasion. This makes polyvalent antivenom significantly more likely to trigger a severe, life-threatening adverse immune reaction in the patient.
We're going to dive deep into those adverse reactions in a moment because they are absolutely terrifying. But first, the dosing protocol in Dr. Fadikemi's notes really stopped me in my tracks.
The pediatric dosing.
Yes. The source explicitly outlines the dosage. Roughly 3 to 5 vials for mild systemic signs where the symptoms are mostly localized. 10 vials for moderate signs like bleeding gums, extensive swelling and drooping eyelids, and up to 15 vials or more for severe signs like total vascular collapse and progressive paralysis.
Yikes.
But here is the detail that completely goes against everything we think we know about pediatric medicine. It explicitly states that the same dose of antivenom is given to both adults and children. Why on earth wouldn't a 40-pound child get a smaller pediatric dose? We adjust Tylenol for weight. Why not antivenom?
It absolutely feels counterintuitive until you remember the underlying mechanics of the injury. When you administer an antibiotic or a painkiller, you are dosing the drug based on the weight and volume of the patient's body to achieve a specific concentration in the blood.
Right, that's standard.
But with antivenom, you are not dosing the patient. You are dosing the venom.
Let me see if I follow. You are trying to mathematically cancel out the poison.
Correct. The goal is neutralization. If that rattlesnake delivered a payload of 50 milligrams of venom into the tissue, the clinical math might dictate that it takes exactly 10 vials of antivenom antibodies to bind to and neutralize 50 milligrams of venom molecules.
Okay, that makes perfect sense.
That mathematical ratio doesn't change based on the vessel holding the venom. Whether that 50 milligrams of venom is circulating inside a 200-pound man or a 40-pound child, there are still exactly 50 milligrams of destructive enzymes that must be neutralized. The child's smaller body still requires the full 10 vials to completely cancel out the snake's full payload.
That is a brilliant way to explain it. You're dosing to match the weapon, not the victim. And the administration of this cure is incredibly meticulous. It isn't just a quick injection.
No, it's a very slow process.
The antivenom is given intravenously, usually diluted in an isotonic solution like normal saline. It's administered slowly at about 5 milliliters per kilogram over the course of an hour. Or they might dilute an entire vial into 500 milliliters of IV fluids and run it as a slow, continuous drip. Now, they don't just give it once, do they?
No, they continually monitor the patient and repeat the heavy dosage every 6 hours until the systemic symptoms completely disappear or the blood finally begins to clot again.
And they don't hesitate to accelerate that timeline if needed.
Right. If the cardiovascular signs continue to deteriorate or if paralytic symptoms worsen, they will hit the patient with another massive dose after just 1 hour. Alongside the antivenom, the clinical team is utilizing aggressive adjunct therapies.
Like dialysis.
They're running dialysis or using diuretics to manage the acute renal failure. They're administering a tetanus toxoid because snake fangs are notoriously dirty. But the clinical notes make a very firm, crucial distinction regarding one specific adjunct therapy: antibiotics.
Yeah, we have a massive tendency in modern medicine to throw prophylactic antibiotics at almost every severe wound just in case. But the notes are very strict here.
They are strict for a very good reason. The rule is only give antibiotics when there are clear, undeniable signs of tissue necrosis or secondary infection at the bite site.
Not just preemptively.
No. A snake bite is fundamentally an enzymatic injury, not a bacterial infection. Injudicious preemptive use of broad-spectrum antibiotics does absolutely nothing to neutralize the venom, it doesn't stop the swelling, and it only further complicates the clinical picture by masking potential fevers or contributing to antibiotic resistance. You save the antibiotics for the dead tissue later.
Now, we touched on this earlier, but I really want to unpack the adverse reactions to the antivenom itself. The clinical presentation dedicates an entire section to this, and it paints a picture of a terrifying medical balancing act. The doctors are essentially forced to treat the devastating side effects of the cure at the exact same time they are treating the bite. It's a massive double-edged sword.
It's arguably one of the most profound immunological tightropes an emergency physician ever has to walk. Because the antivenom contains those foreign horse or sheep proteins, the patient's immune system can violently reject it. These adverse reactions are broken down into two distinct phases, early and late.
Let's start with the early reaction. When does that hit, and what does it look like?
The early anaphylactic reaction typically occurs within 10 to 120 minutes of starting the antivenom IV drip. The clinical incidence is significant. Roughly 5 to 10% of all patients receiving polyvalent antivenom will experience this.
That's a high percentage.
It usually starts with intense itching, urticaria, which are widespread hives, a dry cough, a sudden fever, and abdominal colic. But it can rapidly, almost instantly, escalate into a life-threatening anaphylactic crisis.
So the patient is actively dying from the venom, destroying their blood vessels, and now they're suddenly dying from their own immune system closing their airway. They experience severe hypotension, bronchospasm, where the lungs tighten up and they can't breathe, and angioedema, which is massive swelling of the face and throat. How does a doctor even intervene when the very thing saving the patient's life is literally killing them?
They must temporarily halt the antivenom drip and immediately intervene with a massive counterattack against the immune system. They administer subcutaneous adrenaline, dosed strictly at 0.01 milliliters per kilogram, alongside high-dose intravenous hydrocortisone and antihistamines.
So they're essentially using the adrenaline and steroids to chemically handcuff the patient's immune system. They are suppressing the violent allergic reaction just long enough to turn the antivenom drip back on, allowing the horse antibodies to finish neutralizing the snake venom.
That is exactly what they are doing. It's a chemical hostage negotiation within the patient's bloodstream. And even if the patient successfully navigates that early anaphylactic crisis and the snake venom is neutralized, they are still not entirely out of the woods. There is the late reaction, a condition historically known as serum sickness.
Serum sickness. This sounds insidious because it doesn't happen in the ER, right? It develops days or even weeks after the patient has been discharged and thinks they have completely survived the ordeal. The notes state it typically manifests anywhere from 1 to 12 days after the antivenom treatment.
The delayed nature of serum sickness makes it particularly grueling. The patient will suddenly develop a lingering, spiking fever. They'll experience profound malaise, intense systemic itching, severe arthralgia, which is deep joint pain, myalgia, and painfully swollen lymph nodes.
That sounds miserable.
In rare, highly severe cases, the immune complexes can lodge in the organs, causing immune glomerulonephritis in the kidneys, neuritis affecting the nerves, or myocarditis inflaming the heart muscle.
Why does this happen 2 weeks later? Why the delay?
It's the immune system catching up. During the initial hospital stay, the massive dose of foreign horse proteins from the antivenom circulated through the body. Over the next week or two, the patient's immune system slowly built up its own antibodies against those horse proteins.
It was learning.
Yes. Once the immune system has enough weapons, it launches a massive delayed attack against any residual antivenom proteins still circulating or lodged in the joints, causing massive, painful inflammation.
And the clinical notes point out something incredibly frustrating for the doctors. You cannot prevent it. Giving the patient antihistamines or steroids prophylactically, meaning before the symptoms start, doesn't stop serum sickness from happening. You just have to wait and see if their immune system triggers the attack.
Exactly. Prophylactic management is completely ineffective against this delayed immune complex reaction. If and when serum sickness does occur, the clinical management is entirely reactive.
So how do you treat it?
The patient is subjected to a grueling recovery protocol involving high doses of oral antihistamines, specifically chlorpheniramine to manage the itching, and a heavy course of steroids. Typically, oral prednisolone administered at 4 milligrams every 8 hours for 5 to 7 solid days. It is a miserable, exhausting tail end to an already traumatic injury.
Which brings us, naturally, to the final and perhaps most logical section of Dr. Fedekemi's presentation. Prevention. There's an old medical adage: prevention is better and significantly cheaper than the cure. We have just spent an hour walking through a harrowing, incredibly expensive, highly technical, and deeply life-threatening medical journey. So looking at the epidemiology, how do we systematically stop this catastrophic chain of events from ever starting?
The clinical notes pivot here from high-level pathophysiology to very practical environmental control. Because you cannot reason with a viper, you must manipulate the ecosystem around you. It's about fundamentally denying the snake the two things it actively seeks: shelter and food.
Okay, let's start with shelter.
For habitat control, communities must actively avoid creating artificial breeding grounds and hiding spaces.
The notes are very specific about this. Clear the tall bushes and dense undergrowth immediately surrounding houses. Fill in holes, deep crevices, and cracked foundations where nocturnal snakes like to hide during the heat of the day. And crucially, clear out or burn waste bin dumps regularly.
That last point is paramount. Waste dumps are the cornerstone of the problem, which brings us to the chemical and biological methods mentioned in the data. The presentation advocates for the strategic use of rodenticides around human settlements and the use of pungent deterrents like expired carbide around the perimeter of homes.
So what does this all mean? Let me synthesize what you're saying here. If you look at the whole picture, snake prevention isn't actually about snakes at all. Snake prevention is rodent prevention.
Bingo.
If you leave household garbage piled up near your home, it attracts a massive population of mice and rats. If you cultivate a thriving population of mice in your backyard, you are essentially ringing a dinner bell for the local Viperidae population. The snakes are just following the food chain right to your doorstep.
That is the exact ecological mechanism at play. You are inadvertently cultivating a hunting ground. And then there is animal control. The notes specifically mention that if you keep poultry, you must enclose them in fine barbed wire nets.
To keep the snakes out of the chicken coop.
A chicken coop is an incredibly tempting, contained food source for large constrictors and venomous elapids alike. Deny them access, and they will move on to easier, wilder hunting grounds.
And beyond manipulating the environment, there's personal protective gear. We talked in the beginning about the occupational hazards, the farmers, the hunters, the zoo staff.
The practicality of these physical barriers cannot be overstated in a clinical context. If you are a farmer working in tall grass or a hunter walking through brush at dusk, the strict protocol is to wear heavy, knee-length rubber boots.
Just boots.
It makes a massive difference. If you are zoo staff actively handling these reptiles, the protocol demands knee-length boots, thick leather hand gloves, and heavy protective goggles when attending to the enclosures. This protects against species like the spitting cobra, which can accurately project highly toxic, blinding venom directly into the eyes from several feet away.
It's amazing to think about the scale of intervention. We've spent all this time discussing consumptive coagulopathy, the complex titration of horse-derived polyvalent antibodies, and the management of acute renal failure. But when you look at the raw epidemiological data from Section 2, the fact that the vast majority of accidental envenomations occur on the lower limbs, in the dark, in the brush, it turns out that a thick pair of knee-high rubber boots is literally the most effective medical intervention available. A piece of rubber physically stops the biological wrecking ball from ever entering the bloodstream.
It is the ultimate preventative medicine. Disrupting the physical encounter completely nullifies the need for the entire desperate clinical cascade we have analyzed today.
It's incredible. We have gone on quite a journey today. We started with a simple cinematic trope of a walk in the bush and a rustle in the grass, and we followed that single strike down to the microscopic level. We watched the proteolytic enzymes snip apart the blood vessels. We explored the terrifying paradox of a pediatric hematological crisis where the body clots so hard it bleeds to death, all the way to the meticulous vial-by-vial administration of a life-saving yet potentially anaphylactic cure sourced from hyperimmunized horses. I want to sincerely thank you for helping me pull back the curtain on this intricate, intimidating, and frankly mind-blowing clinical data.
It is a vital and deeply fascinating topic. Understanding the true biological mechanisms of these encounters rather than relying on folklore is the absolute best defense we have.
As we wrap up this deep dive, I want to leave you, the listener, with a final concept to mull over. We spent a lot of time discussing serum sickness as the lingering, painful complication at the very end of this medical ordeal. But I want you to stop and think about the sheer, breathtaking irony of what that condition actually represents. The polyvalent antivenom, the precise, scientifically engineered substance that halted your internal bleeding, restarted your kidneys, pulled you back from the absolute brink of hemorrhagic shock, and unequivocally saved your life, is eventually recognized by your own body as an alien invader. So a week after you have survived the venom, your own immune system wakes up, arms itself, and fiercely attacks the very horse antibodies that just rescued you, causing fevers, joint pain, and misery. It's a profound, almost poetic testament to how wild, unpredictable, and fiercely, blindly protective the human body truly is. Look carefully where you step out there in the brush. Leave the survival knives at home, and as always, stay curious.